Hello, my name is Dr. Aleena Banerji. I'm an associate professor at Harvard Medical School and the clinical director of the Allergy and Clinical Immunology Unit at Massachusetts General Hospital in Boston, Massachusetts. I'm going to start with our first session today, talking about hereditary angioedema, current and future treatment options. The first part will focus on current treatment options. These are my disclosures. Our learning objectives for this first session are to review the current guidelines and unmet needs of patients with hereditary angioedema. To get us all on the same page, we'll start by looking at the initial guidelines and how we approach treatment. And this covers three main goals in the treatment of hereditary angioedema. The first is the treatment of acute attacks, or treating an attack when it starts, with the goal of improving symptoms as quickly as possible. The second main goal is what is called long-term prophylaxis, and this is giving patients with hereditary angioedema regular treatment to decrease and prevent the overall number and severity of attacks in hereditary angioedema. And the third goal is termed short-term prophylaxis, and this is giving treatment to reduce the likelihood of swelling in response to an anticipated event that might precipitate an attack, and this could include a surgical procedure or a dental procedure that is scheduled. Putting these three goals into context, we often think about the guidelines, and there are numerous guidelines that have been published, including from the WAO-IACI, the United States Hereditary Angioedema Association, the Canadian Hereditary Angioedema Guidelines, there's pediatric guidelines, but these guidelines are very consistent in some of the core principles that we talk about in terms of managing patients with hereditary angioedema, and we'll talk about these throughout the rest of the presentation. First and foremost, and again consistent across guidelines, is to make the initial diagnosis as quickly and as accurately as possible. And what we know is that the majority of patients do present with symptoms as teenagers, if not earlier. If a patient is presenting with initial onset of symptoms in their 40s or 50s, then we may not be talking about hereditary angioedema with C1 inhibitor deficiency. And as you can see in this publication, most individuals have initial onset of symptoms around 12 years of age, and this varies slightly in hereditary angioedema with normal labs, but again, patients are presenting with symptoms by the time they are teenagers in the majority of patients that have hereditary angioedema. What has been of concern when you look at these registries or in the literature in patients with hereditary angioedema has been the delay in diagnosis. And what you see here are average delays in diagnosis of more than 5 years out to 10 years. And we have seen this in past years be even longer. But if we can make the diagnosis early and as quickly as possible, then we can help that patient get the right treatment at the right time. In terms of diagnostics, we will talk a little bit about the different treatments. But when you ask patients in this survey, thinking about your most recent attack, please rate the severity of that attack. What you see are a variety of symptoms, which includes fatigue, abdominal pain, abdominal swelling, nausea, diarrhea. In addition, not only are these symptoms very common, but the disease burden is very high. And as you can see in red are the severe symptoms versus in purple, which is moderate, and blue is mild. But again, what this shows is that the disease burden has a variety of symptoms, but the disease burden is also severe in a lot of these patients. In addition to talking about the symptoms, the burden of disease for hereditary angioedema is multifactorial, and this includes the disease course, which we already talked briefly about with the delays in diagnosis, but also the misdiagnosis. We see that patients that are inaccurately diagnosed often present to the emergency room. They have had unnecessary surgery because their symptoms were not recognized as hereditary angioedema. We also know that there's a big burden of the attacks themselves. They can be very painful, they can be very disabling, they can be very disfiguring, and certainly life-threatening, especially when they involve the airway. Separate from the disease course and the nature of attacks, we have to think about the treatment and the costs. Oftentimes, the treatment itself can have a high burden, not only of dollar value, but the indirect costs. So the missed school, the missed work productivity, the need to go to the emergency room or be hospitalized in the middle of having an hereditary angioedema attack. And lastly, and maybe very importantly that we can't forget, is the impact on quality of life. Patients are reported to have high levels of anxiety, depression. They're missing out on social activities. They're not necessarily able to travel. And so all of these factors that impact disease burden certainly need to be thought about when we think about treatment of patients. Let's now move to talking about the pathway, which will frame how we think about the treatment options that are available and are in development for patients with hereditary angioedema. Patients with hereditary angioedema are missing the C1 inhibitor protein or missing the function of C1 inhibitor. And so in this pathway, starting with factor 12, you see that it's activated to factor 12A, acts on prekallikrein to form kallikrein, which acts on high molecular weight kininogen to form bradykinin, which acts on the B2 receptor. This pathway is normally inhibited by the C1 inhibitor protein, which is important because then you do not have unregulated production of bradykinin. However, in patients with hereditary angioedema, they are missing this inhibitory effect of C1 inhibitor. And so the pathway is unregulated, which leads to elevated levels of bradykinin, which acts on the B2 receptor. And that is what is responsible for the increase in vascular permeability and the symptoms of swelling that we see in patients with hereditary angioedema. Thinking specifically about the diagnosis in patients that have hereditary angioedema with C1 inhibitor deficiency, we focus on talking about two different types of hereditary angioedema. The first type is the most common, is about 80% of patients. They do not produce the C1 inhibitor protein. And so when you look at the lab tests, and we're talking about the C4 level, the C1 inhibitor level, and the C1 inhibitor function, they do not produce the C1 inhibitor protein, so their C1 inhibitor level is low and the function is low, along with a low C4 level. In hereditary angioedema with C1 inhibitor deficiency type 2, which is about 20% of cases, they produce the C1 inhibitor protein, but it is dysfunctional. And so when you look at their labs, the C1 inhibitor level is going to be normal, but it does not work. And so the C1 inhibitor functional level is low, and the C4 level is also low. And so it's very important when we're making these diagnoses that we always look at the C1 inhibitor function, because if you only look at the C1 inhibitor level, you will make a misdiagnosis or you will miss the type 2 C1 inhibitor deficiency patients. The third type, which is a little bit more rare, is what we call hereditary angioedema with normal labs. These patients present with symptoms that are very similar to hereditary angioedema with C1 inhibitor deficiency, but their labs are normal. And what we understand now is that there are some mutations in other proteins in the kinin pathway that I showed you earlier. When we look specifically at what are those mutations in patients with hereditary angioedema with normal labs, we have identified 6 mutations to date, and that includes the kininogen mutation, the plasminogen gene mutation, the myofurlin gene mutation, a heparin sulfate glucosamine 3 sulfotransferase mutation, or also shortened to be HS3ST6. We know that there are mutations in factor 12, and lastly, mutations in angiopoietin. And all of these lead to the clinical symptoms of hereditary angioedema that we see in these patients with hereditary angioedema with normal labs. Let's move on and talk a little bit about treatment, and this gets back to our guidelines. Again, guiding principles that are present in the majority of guidelines that are out there, looking at the WAO guidelines, the Canadian guidelines, the US HAE guidelines. And let's focus on the first treatment category that we talked about, which was on-demand or acute treatment. So giving treatment at the onset of symptoms. And what the guideline would say is that there is efficacy and safety across a variety of treatments for on-demand treatment. And this includes C1 inhibitor concentrates, a plasma kallikrein inhibitor, as well as a bradykinin B2 receptor antagonist. And we'll talk a little bit more about the data for these products in the next few slides. We also know that fresh frozen plasma is often effective for on-demand treatment, but it contains the mediators that can lead to increased bradykinin generation, and so can exacerbate some HAE attacks. And so if you use fresh frozen plasma because you don't have access to any other treatments, you do have to closely monitor that patient to make sure that the attack is not worsening. We also know very clearly that androgen and antifibrinolytics are not effective treatments for on-demand treatment. And also epinephrine, corticosteroids, and antihistamines, which are often used to treat allergic reactions, are not effective in hereditary angioedema because this is a bradykinin-mediated process. So let's talk a little bit about the data from the specific therapies leading to FDA approval. And as I mentioned, one of the first treatments that is available for on-demand treatment is a C1 inhibitor replacement product. And this is data from the pivotal trial where they studied C1 inhibitor replacement at 10 units per kilogram on demand, as well as 20 units per kilogram on demand. And what you see in the figure is the placebo dotted line compared to the C1 inhibitor replacement product, or Berinert. And this led to the approval of the 20 unit per kilogram dose of Berinert, or the C1 inhibitor replacement product, because of the statistically significant difference of placebo versus giving 20 units per kilogram on demand of the C1 inhibitor replacement product. The next on-demand product that I mentioned was ecallantide, which is a kallikrein inhibitor. And in this trial now, almost 10 years ago, looking at two different measures of outcome, the MSCS as well as the TOS. And what you see in the patients that were given ecallantide on demand was a statistically significant improvement in symptoms at 4 hours compared to placebo. And these data led to the approval of ecallantide for on-demand treatment. So next, I want to talk about icatibant, which is a subcutaneous treatment given on demand that was approved for HAE. And again, as you can see from the data on this slide, when you compare the data for icatibant being given on demand versus placebo, that patients given icatibant had statistically significant improvement in symptoms compared to placebo. And this was also seen in the secondary endpoint looking at time to onset of symptom relief. And this led to the FDA approval of icatibant for on-demand treatment. And the last or fourth available treatment in the United States for on-demand treatment is a recombinant C1 inhibitor product. So this is a C1 inhibitor protein that is a recombinant protein made in rabbits. And in this pivotal trial, they studied giving 100 units per kilogram intravenously, as well as 50 units per kilogram intravenously. And what you can see looking at the red line, which is the placebo, is statistically significant improvement in primary and secondary outcomes with the recombinant C1 inhibitor product compared to the placebo or saline in this study. This led to the FDA approval of recombinant C1 inhibitor given at 50 units per kilogram for on-demand treatment. So summarizing these 4 on-demand treatments, what you see is both a plasma-derived C1 inhibitor product and a recombinant C1 inhibitor product given intravenously on demand. So the disadvantage is that it does require intravenous access, but the advantages are that there's a lot of clinical experience and really good data that these are effective on-demand treatments. Ecallantide, which I mentioned, was a kallikrein inhibitor, also highly efficacious in the pivotal phase 3 study, but about a 3 to 4% risk of allergic reaction. So ecallantide does have to be given subcutaneously under the supervision of a healthcare provider. And then lastly, icatibant, which I mentioned was the bradykinin receptor antagonist, is a subcutaneous injection, and it's stable at room temperature. But patients have noted some local injection site reactions in some cases when they give icatibant to themselves for treatment of an on-demand attack. So looking now at all of the therapies, we talked already about the on-demand treatments, but let's move on to talking about the long-term treatment options, which are highlighted in green on this slide and include, going back to 2008, a human plasma-derived C1 inhibitor product, or Cinryze. And then in the last 6 to 7 years, in 2017, another plasma-derived C1 inhibitor product, or Haegarda. In 2018, a human monoclonal antibody to plasma kallikrein, or lanadelumab. And then most recently in 2020, an oral plasma kallikrein inhibitor, or berotralstat. So let's look at each of these therapies given for long-term prophylaxis. And what are the guidelines for long-term prophylaxis? And again, very similar across all of the guidelines that I mentioned, but the therapies are available and reasonable for all patients with hereditary angioedema, and it's recommended that every patient is evaluated for long-term prophylaxis at every visit, and the disease burden and patient preference should be taken into account when making decisions around long-term prophylaxis. The recommendation is C1 inhibitor, as well as lanadelumab and berotralstat for first-line agents, whereas androgens are second-line agents because of the side effects associated with androgens. In terms of the data, we'll go back to 2008, which I mentioned was the first therapy approved for long-term prophylaxis. And so this was data giving C1 inhibitor as a replacement product twice a week intravenously. And what you can see on the slide are showing that patients given C1 inhibitor twice a week had statistically significant improvement compared to patients with placebo. And the attack rate was significantly lower in patients receiving C1 inhibitor prophylaxis twice a week compared to patients being given placebo, leading to the approval of this product to be given twice weekly intravenously as long-term prophylaxis. And then fast forward to more recently, this is data for long-term prophylaxis with a product called Haegarda, which is given subcutaneously, but as a replacement C1 inhibitor product. And what you see in the dark green is the data of attack rate for the placebo arm compared to 2 different doses of the C1 inhibitor replacement product. And what you see is a statistically significant decrease in the median attack rate looking at the C1 inhibitor replacement product compared to placebo, which led to the approval of this product for long-term prophylaxis given twice weekly subcutaneously for long-term prophylaxis. In addition to the efficacy data, what they showed was statistically significant improvement in different quality of life tools, showing that not only was there efficacy, but there was improvement in quality of life looking at several different surveys when you gave long-term prophylaxis with C1 inhibitor twice weekly subcutaneously. Moving on to the next product, this is long-term prophylaxis with lanadelumab, which is a monoclonal antibody to active plasma kallikrein that can be given for long-term prophylaxis subcutaneously once every 2 weeks or once every 4 weeks. And what you see in blue compared to the gray, which is placebo, is a statistically significant improvement in the attack rate when you looked at lanadelumab treated patients across the treatment period compared to placebo. And in both cases of the overall treatment period as well as during steady state, there was a statistically significant decrease in the attack rate in patients on lanadelumab compared to those on placebo, again leading to the approval of this product in the United States for long-term prophylaxis. And similar to what I showed you with the data for the C1 inhibitor replacement product given subcutaneously showing improvement in quality of life, similarly in the trial with lanadelumab, you saw a much higher clinically meaningful improvement in quality of life measurement in patients that were given lanadelumab compared to placebo. So not only efficacy, but also clinically meaningful improvement in quality of life. And then the last product that is available for long-term prophylaxis and FDA approved in the United States is berotralstat. This is a once-a-day oral treatment for long-term prophylaxis, and looking at the pivotal data, what you see is a significant improvement in the attack rate in patients given a once-a-day tablet of berotralstat compared to placebo. And you saw that there was a significant reduction in the attack rate, looking at the percentage of patients with 50% or greater, 70% or greater, or 90% or greater attack rate compared to placebo. And again, similar to the other two products that I reviewed, berotralstat had a high safety profile as well as improvement in quality of life. And then most recently at the American College meeting in 2023, long-term prophylaxis data from an open label extension study of berotralstat at 150 milligrams once a day was presented, and they showed that berotralstat was well tolerated and had a good safety profile similar to the phase 3 study. But in addition, this open label extension study showed that berotralstat continued to have a sustained reduction in attacks compared to the patient's baseline attack rate over a longer period of time, suggesting that a reduction in disease burden and that there was a durable treatment effect when you looked at these data from the open label extension study. So in summarizing what we talked about, there are 4 different therapies that are FDA approved with good safety profiles, including a plasma-derived C1 inhibitor product given intravenously twice a week for long-term prophylaxis, a subcutaneous C1 inhibitor product given twice weekly for long-term prophylaxis, lanadelumab, which is given as a subcutaneous injection once every 2 to 4 weeks, and then most recently berotralstat, which is an oral once-a-day tablet given for long-term prophylaxis. We didn't spend a lot of time talking about the attenuated androgens, and they are considered second line because while they are efficacious and do provide good efficacy for long-term prophylaxis, they unfortunately do have a lot of side effects, including hepatic toxicity, impacting cholesterol profile, amenorrhea, causing hypertension, compared to these other 4 therapies that I reviewed with you, which have a lot better safety profile. And then the antifibrinolytics, an example is tranexamic acid. It can be used off-label for treatment of hereditary angioedema for long-term prophylaxis, but again, it's considered second line because of the number of side effects that are associated with that line of products. And so to summarize, we've talked a lot about hereditary angioedema treatment. We've reviewed both on-demand and long-term prophylactic therapies that are available and FDA approved, that are efficacious in reducing the number and severity of attacks, but also improving quality of life. There are many advantages to these therapies, but there are some disadvantages and that may impede compliance. And so we can talk a little bit about some of the newer data as well as new treatment options that are in development that was presented at the American College in our next session. Thank you for your attention.